Okay, so welcome everyone. I might just start anyway, and people can be joining as I'm speaking just to introduce the session, what it's about, and what we're here to do. So, good afternoon, everyone. I'm Joan Bulger with the Irish Global Health Network. The purpose of this community of practice is to bring together people who are working in global health with those who are preparing for global health work. So whether that's overseas in low resource settings or clinical settings at home, we're trying to bring the content of our global health courses to life through experience, real conversation, real connection. So we currently host 2 online courses in global health. One is a practical training, about 15 hours of learning. You can undergo that at your own pace. Some of you might have already completed it. This is originally based on an ACL training that we partnered with the HSE to run pre-COVID. So we've moved the essence of that course online. And then we have a 2-hour specialist medical training in global health. That's a program of the Global Health Committee of the Forum for Postgraduate Medical Training Bodies in Ireland. So both courses are open to all health workers. They're available on globalhealth.ie/e-modules. Ivana will post that link to the chat as well. So we do encourage all participants to enroll on these courses. Complete it in your own time, but at least be familiar with the content for these communities of practice. So some of you may be preparing to travel overseas for the first time. Others might have worked in the field. You're bringing that experience with you. And then quite a number have come from overseas yourself, which is great to see. All very welcome. We've really to learn from each other, and that really is the purpose of this. We'll post a link later in the chat, maybe to contribute some of your ideas to shape future sessions. But we want to give you that opportunity in breakout sessions as well to meet with the speakers. So there have been people as well who have contributed to our open mic call with information about projects you're working on. So we won't get to those projects today in this introduction session, but we'll be in touch on that one separately. Just wanted to sorry, Yvonne, I'm just sending a message there from Eric. I think some people are having trouble getting in, so I'll continue anyway in the meantime. We have some dates for the diary for anybody who is interested in signing up to the series. You can do that at our Zoom registration. Ivana will post that to the chat as well. So our next session is on September 8th, and the topic area is emergency medicine in low resource settings. And then following that, we'll have a session on November 10th. And we've yet to figure out the topic for that, but that will be informed by the contributions you make in shaping the sessions yourselves. And then finally, we'll have an in-person networking session on December the 8th. So we'll have 4 total of these sessions in 2026. And again, you can sign up to the full series at the registration link from Ivana. So also of interest maybe to this group, there is an upcoming course in Galway in June on humanitarian medicine. And until very recently, it still had places left. This is in-person weekend course for all healthcare workers interested in pursuing a career in humanitarian medicine. So the course runs from June 12th to 14th, and it's run by Dr. Jimmy Lee out of University Hospital Galway and University Galway as well. So the link to that will appear as well in the chat when Ivana gets to all the different jobs she has. So at the end of the session, we'll move into our breakout sessions. You'll sit down in smaller groups, and please do ask questions that you wouldn't ask in a big room. That's exactly the kind of learning that this is built for. And then maybe I'll leave it at that for now. I'm just going to hand over to Dr. David Weakliam, who is the head of the HSE Global Health Programme. Thanks to David and Méabh and Bronwyn for coming and joining us today. And we'll see you. I'll see you at the end again. Thanks, everyone.
Thanks very much, Joan. And yeah, I'm delighted to be here to be part of this first community of practice. And we look forward to the engagement. I'm very, very excited to see the diversity of people who are joining today from all parts of the world. I see India, Pakistan, South Africa, Kenya, Oman, the US, and I'm sure there's others that I've not seen. And that is really great because, like, what's a community practice about? It's about people who have a common interest, a common passion, which for us it's global health, who come together to really share together, to learn from each other, to hear each other's experiences, and to be able to discuss issues that are of interest to us all. And so really encourage you to engage, and you will hear three of us speaking now over the next little while, but hopefully there'll be an opportunity for you also to interact. So please, if you have questions, please put them into the chat, and hopefully we'll have a little bit of time to respond to those. And then we will, of course, after that, then have the breakout sessions where you can contribute a bit more. So yeah, so please do engage. And I think this is how the session like this can be hopefully of use to everyone. And with all your experience, I think that can really make a very, very rich discussion between us all. So I'm kicking off with maybe speaking about the current landscape in global health. And it's really to set the scene for our discussion, and then I'll introduce Méabh, and Méabh is going to focus on one of key issues in global health today, which is how we work in partnerships. And then I'll introduce Bronwyn, and Bronwyn's going to speak about decolonizing development and health, and another very important, I suppose, issue for us as we engage in global health. And, you know, I think when I think of the landscape in global health today, like what's so, I suppose, obvious to us all is how much has changed in the space of the last couple of years. I mean, it's been quite dramatic, the events globally, politically, conflict, and things that are having a big impact on health and development and health in the world. And we might be sort of inclined to feel a bit bleak about the whole situation, and certainly there's real challenges at the current time. But I think it's quite good as we look at the current situation in global health to think about where we've come from and how things have evolved and developed over the last period of time. And for me at this stage, you know, in my career, I'm looking back over the 40 or so years that I've been involved in global health and thinking of how the world is today compared to how it was when I started in the 1980s. And what's so striking is how much has improved. That it really is quite a dramatic progress in the world in health. And just to touch on a few aspects of that, I mean, we're talking about a period of time when the population of the world has more or less doubled. It's doubled since the late 70s, and in fact, it's quadrupled in the last 100 years. So while the population of the world has been increasing, people have been actually getting healthier. And when I think back, like I started my global health work in 1982, when I started, there were 2.5 million children died that year from measles. Last year, that was less than 100,000. In 1982, there were more than 100,000 children, or more than 200,000 children paralyzed permanently as a consequence of polio. That's reduced by over 99.9%. Last year, there were less than 200 cases. So that's an example. How much has progressed in child's health, child mortality. There were 20 million deaths approximately in the 1980s annually. Now it's less than 5 million. So this is incredible progress. People are living longer. Life expectancy was 62. Now it's 73, average life expectancy in the world. I could talk about progress in other diseases and maternal health and so on. But it is so notable how much the situation has improved. And we might think, well, what's all that about? What has caused that progress? And it's different with the higher income countries compared to the lower income, because the higher income countries have been improving health for a longer period of time, going back 100, 150 years. And a lot of the progress has not been due to healthcare, but due to improvements in determinants of health. People living better living conditions, better nutrition, better water and sanitation, and so on. Whereas the progress with lower and middle income countries has been more recent, and the role of healthcare interventions has been more significant. A huge amount of the progress that we've seen in the last few decades has been due to interventions in the areas of prevention and addressing disease. vaccinations, treatment of common conditions. So health services have been so important in improving the situation. But of course, while I'm talking in a very positive way about health, it's not the whole picture. And what we see today still is persistent inequality, persistent inequity. And that's the challenge that faces us. And that's something for us to look at is while many people health has improved for most people in most parts of the world, some are left behind. So what is the situation without those people? What are the health needs today, and who have the greatest health needs? And we see, of course, the whole pattern of illness has changed. That whereas 40 years ago it was the major focus and the major issues were communicable diseases. That was a major cause of death, particularly in low and middle income countries. Now we see the transition and so on, people living longer, and now this growing, escalating burden of non-communicable diseases that's facing all countries, including low and middle income countries. So a different pattern of disease that presents new challenges. And while the new challenge of non-communicable diseases is there, infectious diseases haven't gone away. There's still the threat from emerging and new infectious diseases, and we're just out of the COVID pandemic in 2022. But people are still being left behind, and we need to think about who they are, who's left behind. People left behind because of living remotely, geography, ethnicity, gender orientation, maybe stigma from diseases. Who are those people and how are they going to be reached? I think that's a challenge for us. But also thinking of where people are living with the health needs, and that's changed as well. Whereas in previous decades, a lot of the countries and societies, communities where health was poorest was in the lowest income countries, and the big focus was sub-Saharan Africa. So much has changed in the world, with now Africa is progressing, many countries better, and now the big challenges are in countries that are facing conflict, or what WHO might term fragile, vulnerable, and conflict-affected settings. And now we see with conflicts in the world that where the greatest challenges in health are in countries like it's Gaza, it's Sudan, Myanmar, Afghanistan, DRC, places where in conflict where it is so challenging to address health needs. So the landscape is changing. And as it's changed, I think all of us appreciated how health has become increasingly global. We didn't talk about global health so much in the 80s. It was more international health. Now we very much talk about global, and global is that understanding of how increasingly health issues in every part of the world are interconnected. Health in Ireland is affected by health in other countries and vice versa. So health is very global. And what that means is we need to address issues together and learn from each other. I think that really struck home with the COVID pandemic in 2022, where we talked about we're all in this together, and recognizing that a challenge like that needs to be addressed collectively by countries. Similarly with climate change. As the growing impact of climate change emerges, we see this as perhaps the biggest threat to global health in the 21st century. And we see how it's profoundly affecting the environment in which people are living, affecting food supply, water and sanitation, weather events, changing patterns of disease like malaria. And issues then that need to be addressed collectively can't be solved by one country. We could say similarly about the threats of antimicrobial resistance and emerging infectious diseases. They affect countries everywhere. We see in Ireland the situation with our population changing, that the last census now buried 20% of our population in Ireland are people who are born in other countries. So we're an increasingly global population, and with that has implications for health. And when we think about that, we think, well, obviously then the response to that, to global health, needs to be that we work more together, we work more collectively. And yet, isn't it interesting in the last few years how we see the world has changed in the other direction? How we see there's the shifts in the world away from this collective, collaborative, multilateral approach to much more of a unilateral approach, where countries have started to focus much more on their own needs, their own health issues, their own health security. And the focus away from the broader global health needs and priorities. And suddenly we see that the collective agenda, the Sustainable Development Goals, it's no longer such a priority for everyone. We see the UN system being weakened as there's less collective engagement in it. And the most obvious from us from a health point of view, seeing the 1/3 cuts in the budget of WHO, part of a big drastic and dramatic cuts in global aid, down 23%. And this has huge impact on low and middle income countries. And we're seeing studies being done that estimate the health impact in terms of over years to come could be into the millions of lives affected by additional deaths due to loss of funding. So big threats to the gains that have been made in global health and to the whole agenda with the Sustainable Development Goals. And the increased focus, not just on countries' own needs, but also on some of the geopolitical priorities. So conflicts like the conflict in Ukraine, big focus for us in Europe. That's taking away the focus from maybe other countries in crisis, like Sudan. And so this challenged us really to think about the whole aid environment and the growing, and with this, the growing need, the growing humanitarian need. And so resources then being redirected from development towards humanitarian assistance. And last year, for the first time in this century, there was an increase in child mortality rates in the world. And we see that there's increase too in food shortage and hunger. So what's our response to that? And maybe just to finish a few comments about that. I think a challenge for all of us is to recommit to the shared global agenda for health and development. We need the SDGs, we need that commitment to health for everyone, that commitment to universal health coverage. There needs to be a rethinking of aid for health, and that's going on at the moment. There is less aid. That's not going to change. But the situation in countries has to change, where they move away from this dependence on aid for some of the most critical elements of the health system, critical drugs for HIV, family planning, commodities, and vaccinations, that it's unsatisfactory to be dependent on volatile aid for those. And countries need to strengthen themselves in terms of their own domestic financing for health. They have to fund their own priorities. Countries need to strengthen their own locally led development and be less dependent on the external world. But I think if health is going to respond to the challenges of today with the reduction of aid, there needs to be a stronger collaborative approach. There needs to be a return to global collaboration and partnership that I think has been lost in the last few years. It's in the Sustainable Development Goals, the commitment to partnership. But that, in the new reality that aid is less and countries focusing on maybe more on their own security, partnership needs to be embedded in the way countries work together. And partnership is about considering the needs of both sides in the partnership, that everyone engages in the partnership to address shared priorities. And also within partnerships, we need to see how to address the long-standing power imbalances, and Bronwyn was going to speak about that. And as aid has reduced, then the challenge too is also to think about how to, well, it challenged us to think of other ways to support countries to work together. And it's not just about money, it's also about technical cooperation. And I think this is something all of us can become involved with. And there's a real value, maybe more than ever, of working together in health partnerships between higher income countries and low and middle income countries. But in different ways, maybe than we've done it before, based on our shared needs and challenges, based on principles of equality and respect, based on mutual sharing of knowledge, skills, and experience. We all have needs. We all need to learn from each other. We can all benefit on each side. It's not just unidirectional. And Méabh is going to share about some of her experiences in a few minutes. This is a very powerful way to engage in global health today. And for us as a community, or mainly health practitioners, there are opportunities for us to be part of this engagement together through partnership in addressing some of the global health challenges today. And what should our focus be? I think to continue to work in the area of capacity strengthening. As all countries seek to become stronger and able to address their own health needs, together we can collaborate to strengthen capacity, to increase the knowledge and skills needed for countries to lead and manage their own healthcare, and to strengthen training programs so that countries can develop their own capacities, health workforce capacity for their health services. There are other opportunities too with developments in technology and AI, opportunities to do so much more collaborative together without having to travel always to countries. And I think there's great scope, particularly in the areas of training and in service development, to avail of these new technologies. Another issue I think that we collectively need to address is the issue of migration. And in the context of migration, which has reached unprecedented levels, is now more than 100 million people displaced in the world, mainly due to conflict, more than 70 million refugees. So that's a big issue that has health implications for those people and the challenges of meeting their needs, but has implications for the countries that people move to. And so it's an issue for us obviously in Ireland, where people are coming into Ireland. But in the area of healthcare, there's also the issue of the migration of health professionals, health personnel. And another challenging issue is, in the context today, is how to address migration of health workers and to ensure that recruitment is ethical and that countries like Ireland are not draining other countries of scarce human resources and scarce health professionals. Within Ireland, I think for those who are on the call who are based in Ireland, there are opportunities with the current situation to work together in partnerships that will benefit our own work here in Ireland. We can learn from other countries. Learning from the countries who are often with scarce resources can teach us about managing resources better for healthcare and teach us to be innovative, give us ideas of how to do better. There's so much we can learn from each other and in Ireland for our own services to benefit and to become better at looking after our own population, which is increasingly diverse, and to learn how to look after different population groups and people who maybe are in more difficult socioeconomic circumstances. So really just to finish up, so maybe to have a few minutes, maybe to see if people have any comments or questions that they'd like to make, is really what we see a landscape that I think of health globally that's been improving over decades, but in the last couple of years, things have stalled and we're confronting some new challenges, big challenges with reductions in aid, changes in priorities and commitments for health, much more moving away from multilateral to unilateral approaches, and the challenge to find new ways of working, for better ways of aid, to deliver aid better, to working together collaboratively between countries, better partnerships. And I think increasingly to see how can we work together with more equitable global partnerships. So I'm going to finish with that fairly quick overview, touching on a few of the, I suppose, topical issues, prior issues around the context and the landscape of global health today as I see it. And there's a lot more to unpack in all of the things I've touched on. What I'd be interested in just in the next few minutes, if any of you on the call have any questions about anything I've spoken about or any particular comments. You are from different parts of the world, some of you, so you may have different perspectives on things I've spoken about. I think in Ireland, while I've talked about the reductions in aid and a lot of the changes in the way some of the higher income countries are working globally, I would like to say too that Ireland our government and our country is very committed to continuing its aid and in fact has not cut its aid. So I think there's opportunities for Ireland to be a strong voice for global health through this kind of time of change. I don't see any comments on my chat box. I don't know if anybody else has seen any questions. I mean, you can be reflecting anyway on some of these things and maybe think about, for when you're in the breakout groups, you may like to bring up some particular thoughts and perspectives. I think the idea through these sessions is through these discussions and exchanges, we can deepen our understanding of the issues. It's not about lots of information, but I think our understanding of what things affect people's health today, how are they affected, and particularly with health being so global, is how we're connected on these issues and how we can respond to them wherever we are, whatever parts of the world. So I just see one question coming in there is, how is the private sector's role in global health changing over the years as governments wind down their spending? I mean, that's a very good question. And I think it's quite interesting to see how when countries, the higher income countries, maybe the donor countries, traditional donor countries, think about aid, much more is discussed around the links between trade and aid, and seeing that economic development and supporting the economic development in countries is a pathway to development. And certainly it's a pathway to health, because we can see that many of the gains and much of the gains in health in low and middle income countries comes from the improvement in the macroeconomic situation. So as countries become economically better, people's health improves. They live better, they have better, healthier lifestyle. They're also more resource available for healthcare. And I think increasingly too, countries are seeing the opportunities for trade links, that's where the private sector will be working with and working in low and middle countries to help develop the economy. So definitely the private sector has a key role. So that's something to think about. Another comment there is global health as a communication, how it's a benefit under the community as achieving universal health coverage. I'm not quite sure what that, maybe Abhishek, could you just maybe clarify that question? I mean, you've touched on universal health coverage. I didn't speak so much about that, but that's such, I think, a key agenda today. And it's so good to see that as being front and center in the Sustainable Development Goals under SDG 3 for health. Because what's so compelling to me about universal health coverage is that commitment to health for everyone, that no one is left behind, that everyone receives the healthcare they need without experiencing financial hardship. And that wherever people are, that they will get better health. And I think that's really a challenge today, is how to reach those who are unreached. So I think that's an important agenda for everyone. And someone else has talked about the healthcare being more inclusive. How will this impact persons with disabilities? I think that's a great thing to bring up, because I see disabilities as a neglected area within global health. That a lot of disability, it's often hidden in countries because the data isn't always there to show the scale of it. That allocation of resources to people with disabilities in most countries, higher and lower income across the board, is often very low. So I think if we really are serious about leaving no one behind, about the right to health, about universal health coverage, it makes sense to really give more focus to people with disabilities, because they are some of the people who are being left behind, whose needs are not being met. So we'd hope that could be addressed, and maybe that's an issue to be advanced at this time, if health for everyone is going to be achieved. So I think maybe I'll maybe pause at that point, maybe to move on, just in conscious of time, and we'll maybe come back to some of these questions if there's a bit more time. But what I'd like to do maybe is to introduce the next speaker, is Méabh Ni Bhuinneáin. And Méabh is an obstetrician, a gynecologist, a trainer. Méabh has worked in global health for, I think, quite a long time, and is very experienced in rural, remote and humanitarian clinical practice and education. But Méabh is particularly going to focus on partnerships, which, as I've mentioned, I think is really key for us in looking at the global health landscape today and how to work within it. And Méabh has some particular experiences with global partnerships from Ireland. One that I know well from the Mayo University Hospital in the west of Ireland, partnership with the Londiani district in Kenya, and another one more recently through the Royal College of Physicians Institute of Obstetrics, partnering with the East Central and Southern African College of Obstetrics and Gynaecology. So two quite different partnerships, but I think Méabh has a wealth of experience to bring on the subject, and maybe we'll kind of look at some of her experiences and learning from that, and some of the issues that maybe we can learn from, about things like what reciprocal learning looks like. That's a key issue, and what institutions in countries like Ireland can learn from the collaboration. And how do we work really collaboratively? What does that look like? How do we get away from the donor mindset and really practice in an equitable way? So maybe there's some issues there that maybe you might address, and I'll hand over to you.
Thank you very much, David, and good morning, good afternoon, good evening to everybody, and feel free to stretch, take a little tiny micro break, and hopefully we'll have a few minutes to talk about partnership before we continue on with Bronwyn and hear really about how we do things in the right way at the right time. So thank you for the opportunity to be with everybody today, and for those in different time zones for getting up early and staying up late. So from a partnership point of view, I'm going to put up a couple of slides with the help of Ivana, just to have something visual while I just introduce partnership and how we can get excited about partnership. Just to reassure everybody, I'm a clinician, worked most of my working life in a rural hospital. So I'm not a public health specialist, and I haven't had a full career in global health. Perhaps a parallel, maybe 15% of my work life in global health. But it's very interesting to be here with other clear specialists in the area of global health, and I look forward to meeting you in the breakout rooms and to hear your opinions. The first partnership that David mentioned is a hospital partnership. However, it's nested in a community development partnership in Western Kenya, a rural spot in Kericho County, and it's about 20 years old now. And while this is a community of practice for health, our partnership was commenced with peer education to try to reduce maternal to child transmission for HIV. But in fact, when we were invited to look at Ndubisat maternity clinic because of high maternal mortality, it very quickly became apparent from the community that the bigger problem was actually water, sanitation, vector control, and education opportunities for girls and education opportunities for community members to become the leaders of their development. So as a jobbing obstetrician gynecologist, I was really in the wrong place with the wrong skills. But thankfully, the Kenyans are very in Western Kenya, very much like the Western Irish people, very friendly, very motivated, and will quietly take you aside and advise and teach. And the Dubisat model, where the single intervention of a gravity water feed freed up the women and girls and the children from collecting water to actually thinking about other things, growing extra crops for cash, thinking about improving their stove so that there was less wood needed. It allowed the maternity clinic to become a thing in that community. It allowed a focus on health after the needs for water and fuel and education were met. Within that community, the work was very much facilitated by an NGO that included key community leaders, brighter communities. And the ultimate partnership that we have between the two hospitals in Mayo and Londiani would not have been effective without understanding what the community requirements were, what the communities assessed their own needs to be. And the hospital partnership only works because there's a continuing NGO presence in the community, pointing the hospital partners at certain times to consider working together on certain areas. For example, in the beginning, building operating theatres, but not just building them and leaving them, commissioning them, advocating for additional staff to be appointed, collaborating on staff training. And at the same time in Ireland, we were trying to create ways of looking after women and girls without capacity in theatre, because our theatres, we had theatres, but we didn't have the capacity to meet all the needs that were required for surgery. So the thinking about how you build and commission a theatre also brought us to the thinking about how we can actually maybe do some procedures outside theatre, move to more ambulation, move to more minor style procedures without the need for general anaesthesia, so that we could cater for the growing demands of the burden of disease in our community in the west of Ireland. I'll take the next slide, please. At the same time, cervical cancer was beginning to so the DUSAT clinic was very much on maternal mortality, but cervical cancer was also becoming a global issue of advocacy, research development, as screening programs became available, as lower cost screening with simple procedures became available, as the vaccination became available, but sadly is still only reaching 30% of its target, the HPV vaccination. And as Ireland went through its own challenges because it was late to having a screening programme. So the learning from looking at how Curricho County was managing women predominantly with HIV who had cervical cancer contributed to our learning on how we at the time could get our colposcopy services running more effectively, look for screening, sensitising our population through the same public health messaging that was being used in Curricho County. So our partnership while it started in women's health and maternal health and newborn health, it moved according to what was happening in the communities and in global health systems at that time. And I'm still speaking very much as the grassroots, what's happening for the clinicians on the ground. I'll take the next slide, please. The serendipity of what was happening in Kenya in 2006 was the publication of its first community health strategy. And this is the other element of partnership that happens over time. And the community health strategy allowed us to think beyond projects. And it was very much a turning point for if we are interacting on specific projects that were going on in both our communities. Do we need to continue working together? Do we want to continue working together? Do we feel comfortable with how we work together? And the turning point was that with alignment to the community health strategy from the Kenyan government, looking at healthy homes and families and communities, we found that this served us in Mayo also, that we were looking at trying to increase our training of primary care family physicians, or general practitioners as we call them in Ireland, and we were able to use methods that were more sustainable with community-based placement, bring students out to rural areas. The learning from the Kenyan community health strategy to our communities was part of our partnership as general practitioners, both trainees and providers became involved in the work. So we also shared experiences of shocks. So sadly in Western Kenya there were clashes, and in Ireland there were crashes. And then over the next decade we went through COVID together. And these shared shock experiences also strengthened the partnership, if you like the current global situation that David is talking about very much at governance level. The current shocks going on with war, conflict and funding changes, and a move from what many would consider the democratic approach. So the shocks that we shared with clashes and crashes brought us closer together to continue our partnership, and to sit at the table a little bit more equally, because of course we all have biases, and of course there are power differentials, and we'll come into those in the questions and answers. But the sharing experiences, the mutuality of the partnership levels the playing field, and everybody at the table can, as the partnership evolves, it can be more open and more explicit about these inequalities, where having these discussions is considered part of the partnership. So moving beyond rapid project management into actually establishing a relationship that can be sustainable. And I'm sure Bronwyn will pick me up on some of this and challenge me on some of this, and hopefully create a more ethical direction as a result of this community of practice. So I'll just take the next slide, please. So with our partnership, when we realized that we were gaining at the table the reciprocal benefits of bringing back learning for our perioperative care, for our community engagement, for our patient experience, it brought us to being a little bit more open about why are we actually involved in this, and does this help us move away from a kind of a donor mindset? Because, of course, to be honest, many people enter the sector in the beginning to explore, to understand, and to see if there's something to give. And of course, the honest insight is we take so much more than we give. So to work in the green circle of being careful and contextual and relational, in the beginning, it's very important that we can discuss these things and look at what kind of training and reflection that we have while we're in, before and during and after we engage in this space. And I see Sarah Mohan was on the call today, a fellow in global health in Dublin, who's very much working on the partnership between Exicog and the RCPI, so colleges of obstetricians in East Africa and in Ireland. And the underpinning that is long-term collaborative programs run by universities and with government support. And it's very different to a small institutional partnership run by NGOs and individuals in hospital. But what unifies all of these is having the global health curriculum that is available, and how this community of practice has evolved. And now having these discussions so we can learn how to do this collaborative work together more effectively, if that's what's desired, or certainly more relationally, depending on what the priority is. I've 2 more slides, I think. I'll take the next slide. A friend in Kenya, when we were walking from one village to another, and I asked, is it far? And she said, it's not far. After 11 hours and 36 kilometers, she turned around and said, yes, it is far. And the end of that conversation, of course, was it was a great opportunity to chat about journeys and how they are, and where we go and where we don't think we're going. And certainly the partnership journey, we had no idea over 20 years ago that we would still be in a relationship at this juncture. But if we were starting again, we would now have a lot more support in helping us learn how to partner, in finding information about the gaps and learning the needs assessments, in looking at, and I see somebody's already mentioned universal health coverage, looking at universal health coverage from the outset, because with informal healthcare, traditional healthcare, referral systems that are struggling, and then with formal hospital reception of members from the community, in all communities around the world, a universal healthcare approach will make for greater improvement in health at the end of the day. And I want to point out that I'm making these comments based on experiential learning, and that while I've had great privilege and opportunity to work with FIGO in Obs and Gynae, with Brighter Communities in Western Kenya, with Médecins Sans Frontières, and with the RCSI Global Surgery Institute, despite all of this, I still feel that I'm a beginner in this domain, and I'm still, as a clinician, we really have to respect how important it is to work interdisciplinary, and to know where to go to get the guidance and the information on how we approach this global health partnership together. And with the HSE Global Health Programme, the Irish Global Health Network, and formerly Esther Ireland, we received tremendous support over the years for bringing our link, our hospital link, into the wider partnership that it has become today. I'm very happy to take questions or to hand back to David, who I think is going to introduce Bronwyn.
Yeah, thanks very much, Maeve. Yeah, that was really, really very, very good. And I think you make the compelling case for partnerships today and why they're so important and valuable. And I think they speak to today's agenda, where countries are focused on their own health needs as well as supporting other countries, and to see the value of partnerships like the one you described that can benefit our own health services in Ireland, that we can benefit from these links from just the learning and the ways you described, but also by supporting partners in other countries to develop more resilient health systems. That in turn is a benefit to us because that will contribute to global health security. So we all benefit. And I think that's one of the values of partnerships. It addresses everyone's agenda, and it will both contribute to maintaining the focus on the health agenda and universal health coverage, but also while being mindful of some of the priorities that some of the higher income and donor countries are experiencing. Now, we do need to move on because of time, but we will be in the breakout groups, maybe a chance to bring up some questions. But I think I would like to move on then to introduce Bronwyn April, who's Education and Outreach Coordinator with Comhlámh. And Bronwyn is going to offer a short reflective input on decolonising development and global health practice. And I think this is such an important issue in the world today to really, I think, respond to what has been a historical imbalance between the higher income and the lower income countries that we've seen now the impact of when aid drops, that suddenly the impact is with the poorer countries. And so Bronwyn's going to speak about that, and I think also invite all of you on the call and clinicians and global health practitioners to consider what decolonisation can look like in daily practice. So Bronwyn, I'll hand over to you.
Thank you so much, David. So I just need to put in a disclaimer. I am not an expert. I am just going to be offering a reflection on this because decolonisation has become such a topical word and a topical theme that people have been touching on. And there's so many entry points into the work and the word and the concept of decolonisation. And I thought that instead of bringing in a big theoretical framework, I'm just going to talk about or offer up a reflection on how I entered into this work. And it wasn't through studies or anything, but really through just personal experiences. So just to say good afternoon, everyone. Thank you for having me here. Thank you for being here. Good afternoon, good evening, good morning. I don't know what times we're working with. I will always say that you could have been anywhere in the world today, but you chose to be here and spend a few minutes with us. So I just want to thank you for the time that you're spending here today with us. I just want to reiterate and say that when I speak about decolonising development and global health practice, I'm not speaking as someone who has mastered it. I am speaking as someone who's still being changed by it and still being unsettled, still learning, still unlearning, still relearning what it asks of me in my body, in my work, and in my relationships. So I'm not offering a finished answer today. I'm merely offering a reflection, and I hope that it's a reflection that opens up something for all of us. For me, decolonisation is not only a framework, it is not only a critique of institutions, even though it is that as well. It is about the histories and present systems that still shape those whose knowledge is seen as legitimate, whose voices carry authority, and whose lives are treated as more valuable than others. And I've come to feel that decolonisation lives much closer to the skin than that. It lives in how we work, how we lead, how we listen, how we rest, how we respond to harm, and how we try to remain human inside systems that often reward detachment, speed, hierarchy, and endurance. My own way into this conversation was not mainly through theory, but it was through burnout. That is not separate from this topic for me, and it is part of how I have come to understand decolonisation. Last year, I wrote a little blog piece for the IJHN in the Equity blog called Power, Inequality and Decolonisation and Loving My Recovery. I wrote very plainly that I'm still in the process of recovery from burnout, and that is not just a story in the past tense. I also wrote about my right to remain in Ireland that is tied to my work permit and my permit is tied to uninterrupted employment. I name that not because of a personal difficulty, but as a structural form of power over. The blog itself frames this whole conversation as a shared reflection rather than a lecture, and I think that still feels right for me right now. Because one of the clearest ways I understand because that is one of the clearest ways that I've come to understand decolonization. Not as something abstract, but as something that enters the body, something that shapes fear, silence, exhaustion, and survival. So when we ask about decolonization in global health, I would say that it means asking how power shows up in everyday working life, not only in policy documents, but it also asks who gets to define the problem and who gets to define the solution. So I'm covering some of these topics. I know it seems quite extensive, but it's really just a story. And I thought that I would just share some of these agendas, points, and I'm sure that they could share the slides with you as well. So decolonization also means asking whether our institutions value relationship and repair, and not only productivity and visibility. It asks whether the language of impact can sometimes hide unequal power. And sometimes in global health, we speak as though the real work of decolonization only happens at the level of ministries, universities, donors, large agencies, or formal policy reform. And of course, those spaces matter, and they matter a great deal. And if we leave decolonization only at that level, many people feel paralyzed. They think, I cannot change the system, so what can I really do? And I do not think that is where we should be stopping, because macro and micro levels are always connected. And it lends back to what Maeve and David were talking about, how everything is connected, the global to the local. Systems are reproduced through daily habits, through meeting culture, through whose voice is deferred to, through whose expertise is named, through how quickly we move, through whether disagreement is safe, through whether community partners are brought in only after the agenda has already been set, through whether clinicians and practitioners imagine themselves as rescuers, experts, companions, or learners. That is why the phrase finding your lane in the revolution is useful to me, because not everyone can redirect global financing, not everyone can challenge the WHO, and not everyone can change a ministry. Yet every one of us is located somewhere inside of power. And from where we stand, we can begin to notice how we participate in it, how we benefit from it, how we are constrained by it, and what different practice might look like from where we are. And that brings me back to my burnout. Burnout is often individualized. It is spoken about as a poor coping, poor time management, or a lack of resilience. Sometimes those individual dimensions are real, but in many helping professions such as global health, burnout is also a signal. It tells us something about systems that normalize overwork, urgency, hierarchy, and emotional disconnection. It tells us something about cultures where being useful becomes more important than being well. It tells us something about the moral pressure to keep serving, even when the conditions of service are themselves dehumanizing. And I want to be very careful here. Rest on its own is not decolonization, and wellness language has been and continues to be commodified very easily. But where rest becomes a refusal of extraction, where it restores dignity, where it protects imagination, and where it reminds us that human worth is not earned through output, then I do think rest can become part of decolonial practice. One of the most powerful ways I have made sense of this is through the language of power within, power with, power to, and power over. In the blog piece, that framework is linked to the typology developed by two formidable researchers, Finnicklassen and Miller, and I used it as a way of understanding my own lived experience, my idea of solidarity, and also recovery. For me, power over was not only domination in the obvious sense, it was also the quieter pressure of precarity, compromise, self-monitoring, and the fear of speaking too plainly. But power with showed up in solidarity. In the organization that I'm currently working at, Comhlámh held space for me and continues to do so. In the friendships where care was shared, and in the simple fact of not being left alone inside exhaustion. Power too appeared in the return of my imagination, my ability to laugh again, and to act, and to love, and to breathe. And power within slowly re-emerged as I remember I am more than what I produce. And this all matters for global health because we often spend a lot of time analyzing power over institutions over communities, donors over partners, experts over patients, employers over workers. And we do not spend enough time building power with, especially with each other. And I think power with may be one of the most important correctives we have, not only to burnout, but to colonial practice, because it asks us to move from control to relationship, from expertise as possession to knowledge as co-creation, from leadership as command to leadership as facilitation, accountability, and mutual transformation. So what might that look like in everyday settings for clinicians and global health practitioners? Because I know this all sounds really la-di-da, all airy-flairy, and might not just be possible. But it's sometimes in the very small ways in how we show up. But small does not often mean unimportant. It can look like greeting people properly and not rushing past their personhood. It can look like checking in before launching into tasks. It can look like asking who is not in the room and who should be in the space. It can also look like noticing when an institution invites participation but keeps decision-making centralized. It can look like sharing platforms and resisting the impulse to speak first. It can look like citing and resourcing work from the global south or global majority, not as token inclusion, but as intellectual leadership. It can look like slowing meetings down enough for disagreement to be possible. It can also look like making room for emotion, memory, intuition, and embodied knowledge, and not only the language of metrics. It can look like asking whether what we call capacity building is actually one directional and paternal. And it can also look like stepping back when our voice is overrepresented and stepping in when silence would protect them. These things may sound ordinary, and ordinary practice is where culture is made, and culture is where decolonization either becomes real or remains a performance. I also want to bring in something around shame. I do not think that shame changes people very well. I think we've all had a dose of that when we're trying to go on a flash diet or trying to do something really impromptu and we try and shame ourselves into action, and we all know that doesn't work. So often I feel shame makes people defensive or frozen or invested in appearing good rather than actually being accountable. So in global health and development, many of us are implicated in harmful systems, even when our intentions are sincere. Helping professions are not innocent simply because they help. Care can still be paternalistic. Solidarity language can still conceal domination, and inclusion can still be conditional. So for me, the more useful starting point is not shame, but it's accountability. It means asking not, am I poor, but am I willing to repair? Am I willing to listen when my practice reproduces harm? Am I willing to share power, resources, visibility, and decision making? Am I willing to stay in relationship when it becomes uncomfortable? And am I willing to be changed by what I hear? And I think this matters really deeply in North-South partnerships. Because if decolonization is taken seriously, then partnership cannot simply be about transfer, expertise, and project delivery. It has to become a question of leadership, agenda setting, trust, reciprocity, and material power. It begs the questions around who frames the priorities, who holds the budget, Who is asked to adapt to whose timelines? Who is expected to produce evidence in someone else's language? Who is celebrated as innovative? Who carries the risk? And who accumulates the prestige? For those of us in Ireland or in any other northern-based institutional setting that asks us for humility, it asks us to stop imagining ourselves as the natural center of knowledge and coordination. And for colleagues in the global south, the global majority, this may resonate differently because decolonization is not merely an intellectual brand or trend. It is tied to long histories of dispossession and to present arrangements that still distribute voice and value unequally. So perhaps the invitation is shared even if the stakes are not equal. The invitation is to practice solidarity rather than extraction, and to build relationships that do not produce hierarchy under the language of partnership. And I think the most hopeful thing I can say is this: decolonial practice does not only begin only when the whole system changes. It also begins in the smaller places, in the ordinary, in the places where another way of being becomes possible. And I recognize that in my own life, in my organization, and in my friendships. Those spaces did not merely help me to endure a system, they also showed me a different social logic, a different way of valuing people, and a different way of relating. So my invitation to clinicians and practitioners is not to wait until you have the perfect framework or the perfect politics, to start where your feet are. Ask yourself, where do I have power over, and where could I move towards power with? What in my daily practice is extractive, even when it appears efficient? What have I mistaken for professionalism that is actually disconnection? What would shared humanity require from me? What kind of colleague, partner, or practitioner am I becoming through the way that I work? And what is one practice I could change this week that would make more room for dignity, rest, truth, and shared leadership? For me, decolonization is not only about dismantling what harms, it is also about remembering what helps us become more human with one another. Sometimes that begins in policy, and sometimes that begins in protest. Sometimes it begins in saying no. Sometimes it begins in rest, in friendship, and sometimes it begins in the courage to stop performing certainty and to start practicing relationship. I'm still walking the path. I'm still learning, unlearning, deconstructing. And I know now that the inward practice and outward practice cannot really be separated. How we hold ourselves shape how we hold power. How we relate to our own worth shapes how we relate to others. And if coloniality lives both in our systems and in our sense of self, then decolonial practice must live in both places, outwardly and inwardly. So I don't think decolonization begins only when institutions transform. I think it also begins in the ordinary places where we choose relationship over hierarchy, truth over performance, and shared humanity over power. Thank you.
Thank you very much, Bronwyn. That was wonderful. I mean, there's nothing that can beat a personal story, and I think it's just so much we can learn from that. And I think it challenges all of us. It comes down to the individual, to me, to relationships, to how I behave. And I think you've given some very, very practical ways of thinking about that and how we can respond ourselves. So thank you very much for that.
Thank you.
So we're at a point now where we want to move into the breakout groups. We're just a few minutes behind, but we have the full time that we wanted to have for about 10 minutes. And what we're planning to do is to randomly allocate each of you to a group. Maeve will be in one group, Bronwyn will be in one, and I'll be in one. So each of us will help facilitate the groups. I'm really just going to ask one question that we'd like you to hear from you about is, what's the one thing that makes cross-country collaboration in global health actually work? See, we're all back. Welcome back, everyone. things suddenly were abruptly, we were just getting into a nice flow of conversation, and then we were suddenly back. I don't know if we may not have much chance to feed back, and if I can, maybe before I know that some is going to be wrapping up shortly, but just say we had some very good discussion and just some points or very good points made around things that are important in collaboration, equity as a cornerstone of really fundamental to everything else being effective in a partnership. That came up. And I think that the value too of having this type of having a platform for exchange of best practices and experiences, and suggestion to include policymakers in that. So that's maybe something we can think about. And think about partnership work in humanitarian settings. It's very, very challenging. And one of the points was made about the importance of good planning in partnerships and humanitarian response to avoid duplication. Points that come up in ours. Anybody quickly want to share anything back from the other groups before we wrap up? I see Maeve has put something into the chat.
You're on mute, Maeve.
Maeve has highlighted teamwork, cultural adaptation of interventions, cultural humility, shared goals becoming more cost effective.
Thank you. I lost the ability to unmute. So a very, very engaged group. So from Tahir and Sagan, the teamwork and cultural adaptation from Sydney is very important. Cultural humility from Sagan, shared goals from Sarah, and then we're just getting into a question as to how we become more cost effective at this time. How do we prioritise? How do we look for different ways to secure funding? Because certainly it's quite a crash at the moment.
Sounds like an interesting discussion. All right, Bronwyn, any quick feedback from you?
I think just the synopsis was just to meet people actually where they are and what that actually means in practice, because it sounds all lovely, but to actually do that would require us to really think about what are some of the barriers people are experiencing and to actually address the barriers as opposed to the person. And therefore, that would lend itself to better cooperation or collaboration.
Great, thanks very much. So I hopefully you found that discussion useful. It was quite short, so maybe we'll in other times we'll have more chance to get into some of these issues a bit more. I see that's been posted. Cara has posted just something in the chat just for feedback. We really appreciate feedback because that will really help inform the future events, and we really want them to work well. So any feedback you have would be very valuable for us. And on that note, I think we're running shortly out of time, so I'm going to hand back to Joan, who's going to do the final wrap up. So thank you very much, everyone.
Yeah, and again, I'd encourage everybody, if they could, while we're live and still on the call, and we have a few minutes to please, and we'll take you a couple of minutes to fill out that form. Really, the idea is to shape future sessions and talk about, maybe what topics you might like to hear from or hear about, types of speakers you might like to hear from. Any other sort of areas or formats we should consider. Anything at all. This is our first time doing this, so your feedback really helps us now to shape what's coming next. And as well, I just wanted to close really and say thanks so much to David and Maeve and Bronwyn. Thanks to everybody who joined us, those who are online and in the room, and those who will probably join us on the recorded feed afterwards. We encourage everybody to sign up to the series. That's available on globalhealth.ie. If you sign up to our newsletter on the sign up link on globalhealth.ie, you will also automatically get news about the different events and communities of practice we have coming up. But a reminder again, our next one is on the 8th of September. We'll focus on health emergencies in low resource settings. That will include a public health piece, humanitarian and disaster response, disaster risk reduction, and we'll send details closer to the time about speakers, but we hope to see as many of you as possible. And thanks again for coming. And that's it, really. We don't take more of your time, but if I could just leave on the note to please complete those feedback forms, that would really help us for the next session too. And thanks to everyone for joining. That's it, really. Goodbye, everybody.
Thanks, Joan, for organising. Thanks, everyone, for joining. Look forward to the next one.